Thank you very much indeed. Next speaker is Effiona Andah, and talking about palliative and end-of-life care experience of people of African and Caribbean descent during COVID.
Thank you. Hi everyone, my name is Effie. I am an academic clinical fellow and GP trainee in Manchester. So today I'm going to be talking about palliative and end-of-life care experiences of people of African and Caribbean descent. This work was done as part of the NIHR Policy Research Unit with older people in frailty, and was done across kind of two universities, University of Manchester and Newcastle University, as part of a wider team. So we know people of African and Caribbean descent experience some of the highest levels of material disadvantage, with COVID-19 deaths twice as high as those in the white population. We also know that they're less likely to access end-of-life services, but what we don't know is sort of why that access is limited and sort of how COVID-19 had an effect on this. So this led us to our research question looking at the views of relatives and carers who'd been bereaved, as well as that of health and social care professionals who looked after people of African and Caribbean descent, specifically kind of during the COVID-19 pandemic, so between April 2020 and March 2022. So we kind of sought advice from the PPIE group about how best to go about this, and they were heavily involved in this research in general, and qualitative semi-structured interviews was identified as one of the best ways to get as much information about this as we can. So we carried out wide public recruitment, contacted over 150 kind of organizations, and we ended up interviewing 26 bereaved relatives and 13 health and social care professionals. We analysed this data using thematic analysis, which gave us our themes as well as some sub-themes. So the three main themes identified were representation, personalisation, and awareness and access. And this kind of led us to sub-themes as well of discrimination and racism, culture and religion, the impact of COVID-19, as well as access to care and support before and after death for relatives and bereaved relatives, as well as the communication in this and their involvement in decision-making. These sub-themes did overlap across the main three themes as well. So looking at our first theme of representation, so discrimination and racism was kind of brought out from this data and highlighted in this data. So family members kind of described an overall mistrust in the healthcare system, usually based on previous experiences or experiences of those that they know. They were concerned about being treated fairly. One of the quotes highlighted is, so if you've experienced racism within society, why would you then think in health that you're going to be treated fairly? And so because they had this kind of viewpoint in general, this affected their access of healthcare as well. They also highlighted that there was lack of representation of people of African and Caribbean descent during the COVID response. So some participants highlighted that actually the frontline workers that were highlighted in the media, none of them seemed to be from African and Caribbean descent. And although they were hearing that, unfortunately, lots of, or quite a few healthcare professionals who were of African and Caribbean descent were unfortunately being affected by COVID. It was interesting to note the health and social care professional views of this. So some professionals felt that racism and discrimination was entrenched in healthcare. And interestingly, the health and social care professionals were more likely to kind of highlight this specifically, and as opposed to relatives who thought, oh, maybe we're just, being sensitive, but health and social care professionals were basically like, it's entrenched in that, and they felt like services are built around certain people at the cost of others, and that there was a superficial approach to equality and diversity. They did obviously highlight that this was exacerbated at times with kind of intense strain and resource limitation, as was seen during the COVID pandemic. Some people describe like the snowy white peaks of the NHS, as well as feeling that they had to bite their tongue and couldn't confront, these instances when they did see them, because they felt it might sort of cause a necessary confrontation. The second theme kind of highlighted was personalization. So relatives kind of described a lack of that specific cultural and religious sensitivity in their experience of palliative care services. So they didn't expect service providers to really understand their needs and experiences, and they felt like they were missed out, and they missed out on services because of assumptions that were made. For example, some people highlighted that they felt like they were kind of known to take care of their own, so they weren't really offered these bereavement services, and so they were likely to more carry out these caring roles. But unfortunately, during COVID-19, they expressed sort of feeling more isolated in doing that. They felt like they didn't see themselves represented in palliative care and in bereavement services. So when people did know about it, they didn't feel like they could access it. The impact of COVID-19 affected the person-centeredness in care. So professionals, the health and social care professionals, felt that it did suffer partly due to the pressures of the COVID-19 pandemic. And one thing that was highlighted kind of across the board was they felt that this lack of communication, so there were no visitations, especially early on in the pandemic, led to that them and us mentality, and they felt like they just had to take on what was being said by healthcare professionals, because they couldn't see it, they couldn't see what was happening, and they felt they weren't able to ensure that good care or have that care that they normally would at other times. So some of the specific kind of religious ceremonies and things that they would want to carry out wasn't able to happen, which left them feeling very distressed. The third theme that was highlighted was awareness and access. So access to care and support before and after death left families feeling like they had to care for the relatives on their own without any adequate support or equipment or knowledge. Their experiences led to kind of significant psychological costs, and a lot of them expressed this distress at not being able to, even from usually they'd have that community support even if they didn't access sort of NHS resources, and during the pandemic they didn't even have that at all, and that took a big toll on them. Some people did highlight that if you knew the system, you were more likely to get better care, and if you fought for your rights. So one of the family relatives expressed that their sister was like a social worker, and because of that, or a social care manager, and because of that, they felt like they were able to access better care because they were able to advocate for themselves because they knew more information. Both relatives and professionals kind of described that people of African and Caribbean descent didn't know about palliative care services available. They described barriers to equitable care because they felt like there was an ignorance of how to provide care to their specific community. And there was also reluctance to ask about it. Some relatives highlighted that even, for example, within the African and Caribbean, people of African and Caribbean descent, the cultures are very different, even if it's the same country. First of all, there are like many different countries, but even within the same country, like there's so many differences which aren't often highlighted, and there was that assumption of a kind of similar care being given to those involved. I think they also highlighted, professionals specifically, of that fear of making a mistake in providing that care, and so these all acted as kind of barriers to receiving good end-of-life care. Communication was a big thing that was highlighted as well. Again, we've talked about the visitation rights, causing people not being able to have that communication with healthcare staff about how their family is doing. They felt that it was poor quality when they did have telephone contact, and some lacked, and it lacked clarity. The use of technology was seen as helpful, but actually that wasn't available across the board. So some places had video facilities to be able to talk with people. One relative highlighted specifically a good experience was that the staff members actually used their own personal phones to call so that they could have that access, which they really, really appreciated and helped them in that bereavement process. However, that wasn't universally available, and most of the experiences were of poor care. This also links in with that involvement in decision-making, because a lot of the relatives felt like there was a lack of involvement, that they were basically being told that this is what is happening, and they didn't feel like they could have any input at all to it. And there was a lack of clarification of the roles they could play as well in that. As this quote highlights, they felt that they just had to trust because they couldn't see what was happening, they didn't know what was happening, and they just had to kind of go along with it. So one of the things we wanted to find out from the research, alongside kind of like the barriers to care, as well as their recommendations for change. So they highlighted that better representation of people of African and Caribbean descent, even in just the kind of publicity and public-facing material, as well as in the workforce in general, would make them more likely to access that care. Acknowledging the stereotypes that I had of people of kind of African and Caribbean descent in kind of taking care of relatives would help to also identify and tackle this, and so help them to be able to more kind of access this care. Personalization of the services as well, and respect of their cultural and religious beliefs, and the diversity within that was critical. Again, highlighting that they wanted to be asked about how that could be done. That awareness and access as well, in terms of building professional confidence and competence, which the professionals interviewed also highlighted themselves to provide that culturally sensitive care that was needed, either through training and education or working with community and religious groups and leaders. And raising awareness in general of palliative care services and their presence and the value of them in these communities was important and recommended. So in summary, palliative care overall was perceived as inadequate during the pandemic. However, it's important to highlight that it wasn't just across people of African and Caribbean descent. This was more so, even the participants themselves highlighted that as a whole, this suffered greatly. Participants felt that better representation, personalization, as well as awareness and access could lead to improvements in care. And palliative care services and local communities working together, they can learn from each other and help to enhance this care and awareness of these services, so that we can kind of promote this appropriate care for all. And significant investment in sort of the services and within these communities is required to help them access better end-of-life care and palliative services as a whole. Thank you.
Thank you very much, Effie. Are there any questions? Yes, please come to the microphone. Oh, there's somebody behind you as well. Oops.
Hiya. Thanks for such a beautifully presented and powerful presentation. It was so interesting to see that you covered so many things. I was just wondering, were the people you wanted to speak to, were they receptive to talking about something that you wanted, like a sensitive issue, a sensitive topic?
So that was something that was actually, we found difficult during our recruitment process. So even though we contacted like 150 organisations, as well as word of mouth, and even within the PPIU group, which was made up of people of African and Caribbean descent as well, kind of recruiting through that, we did find difficulty. So actually, in September 2021, the decision was made kind of as a team to include the viewpoints of health and social care professionals to kind of widen that data set that we had. And it did end up bringing in kind of like an important perspective. So it was actually very difficult people didn't really want to talk about it. Yeah, so recruitment was difficult.
Thank you.
Yeah.
Time for one more question, I think.
I was just wondering if there was a sort of a difference between community palliative care and hospital palliative care that you noticed in sort of the feedback from patients.
Yeah, so in our data, we didn't have as much, it was more so hospital care that was focused on, so we don't have kind of enough information to draw kind of specific conclusions about both, although we did get some community services within the data, those who'd experienced kind of care in community within the data set. But mostly it was more so kind of hospital, so yeah.
Thank you very much for that.
Thank you.
Thank you. And last but not least,